Good morning, everyone. Welcome to the Medicine Ground Rounds. I will introduce our speaker this morning since Dr. Kassam is busy in an emergency meeting due to the COVID-19 situation in the zone. It is anyway my pleasure to introduce Dr. Nicola Murgia from the University of Perugia in Perugia, Italy. Dr. Murgia graduated at the University of Perugia in 1997, then obtained 2 specialties in occupational medicine and clinical immunology and allergy, and is currently associate professor at the University of Perugia in occupational medicine. He completed a PhD at the University of Gothenburg in Sweden in 2017, and he is an international expert in the field of respiratory occupational disease. He is the author of an important statement from the American Thoracic Society and the European Respiratory Society published at the end of last year about the occupational burden of non-malignant respiratory disease. And this is an emerging problem, something that can be very relevant also for us in Alberta due to the heavy industry we have. So it is my pleasure to introduce Nicola, who is going to talk about occupational burden of non-malignant respiratory disease. Welcome, Nicola.
Thank you, Giovanni, and good morning, everybody. I'm very pleased to be here to present this important issue, at least from my point of view. And the title of my presentation is exactly, this is the occupational burden of non-malignant respiratory diseases. When we talk about the relationship between work and health, we have to consider that our job, I mean, any kind of job, it's an important part of our life, of our time, and also of our, I mean, social status in a broad sense. So work is something to defend, it's something important. And we have always also, especially if we're working in a kind of intellectual work as we are doing actually, we have a kind of romantic attitude to the manual work. We consider manual work a kind of place where there is no stress, no problem. You can work outside in the nature. But unfortunately, some kind of work, some kind of manual work is not that, I mean, that nice. It's dangerous. The reality is this. So we have to consider dusty trades in a broad sense, something that can be dangerous for our health. It is something that is quite known in our education. We know that we have some kind of traditional workplace exposure that can be very dangerous, like asbestos, especially there in Alberta, where you have one of the most important cohort of insulators using asbestos or have used asbestos. But also other dusty trades like trades where silica is present and can risk silicosis. The problem of dusty trades is known since really the ancient era. Plinius the Elder in 60 after Christ report that miners have to protect themselves with calf bladder to avoid this dangerous dust. So it's a very old problem. And more recently, in the 16th century, Paracelsus, quite known physician of the time, talked about miners' consumption. So there was already a disease related to dust. The father of occupational medicine, as we know already, is Bernardino Ramazzini. And Bernardino Ramazzini recognized that also people working in other dusty trades like stone cutters or quarrymen were at risk of this consumption and respiratory disease in a broad sense. We have a more, defined disease just in the 19th century, where von Senker, Dr. von Senker, talked about pneumoconiosis in a broad sense. And we have to wait until 1870 when 2 Italian physicians making an autopsy on a worker exposed to silica found for the first time a disease that named silicosis. Silicosis is an occupational lung disease. It's a disease where the burden is occupational. So all the contribution is occupational. And occupational lung disease are under the big umbrella of work-related lung diseases. Beside the occupational traditional lung disease like occupational asthma or silicosis or asbestosis, we have, as I said, we have a complete burden related to that. We have also other diseases. These diseases are the common diseases like COPD or even other lung disease as idiopathic pulmonary fibrosis. They are multifactorial lung diseases where genes and environment are contributing to the development of the disease itself. So in this kind of more frequent lung diseases like COPD, IPF, sarcoidosis, where the exact etiology is not, I mean, we have not 100% contribution of something. The role of occupation could be present. And this is something known since the end of the Second World War, where some researchers report that dusty traits, even within social class, are linked to chronic bronchitis mortality. It was quite an important point. But after a few years, we recognized that the main risk factors for chronic bronchitis and also for COPD lately was smoking. And smoking lead in some way the field of the causes in the COPD and other airway diseases for many years. And it's right. I mean, smoking, first-hand smoke and second-hand smoke represent the main risk factors for these diseases. But we know that not all the people with COPD or chronic bronchitis are smokers. Someone could develop this disease for other factors. And for that reason, some researchers at the end of 80s start again to think that there is something that could contribute and could cooperate also with smoking to give this kind of airway diseases. One of the most important research in this field was Margaret Pearce, that you may know because in the late part of her career, she worked and lived in Canada. And Margaret was an astonishing researcher and bring back this idea that occupations and astral traits can be of some importance for this disease. After Margaret's work, there have been produced a lot of documents, papers, and data and evidence that occupation can contribute, not at the level of smoking, of course, but they contribute to COPD and other airway chronic diseases. For that reason, the American Thoracic Society and the European Respiratory Society in 2003, they produced an important document, a statement, where they report at least this task force of experts report the occupational contribution to the burden of airway disease. After more than 15 years, the American Thoracic Society and the European Respiratory Society decide that it was time to update this document, including also other important diseases coming up in the last 15 years. And for that reason, was appointed a task force, and I'm very honored to be a part of this task force, which produced this document. And the document is the one that Giovanni told us before, and is a statement of ATS and European Respiratory Society with the title, The Occupational Burden of Non-Malignant Respiratory Diseases. In this statement, we report also not just airway diseases as the first statement, but we put some light also in other multifactorial, other common diseases that could have an occupational contribution. About asthma, we found similar results of the first statement. So the contribution of the occupation in asthma, and I'm talking not to in occupational asthma, which is a typical occupational disease with 100% of contribution of occupation, but we are talking about common asthma, allergic asthma, pneumoallergic asthma, the common disease very prevalent in the population, and the occupational contribution to asthma is 15%. And it was something that was clearly similar to what John Balmes and the first statement found in 2003. So as you can see in this picture, multifactorial disease have several components altogether, contributing and interacting often to give the disease. And it happens also in COPD. The COPD part was the part which I have contributed more. And as you can see, there is a lot of evidence that even if the homogeneity of the study are not very, very deep, well, there is an evidence that occupation can contribute to the etiopathogenesis of COPD. And this attributable fraction is 14%. That is slightly less than John Balmes and the other found in 2003. And it could be in some way related to the improvement in the hygienic measure you could find in these last 15 years. About another important disease, which was not covered from the first statement, by the first statement, I'm talking about idiopathic pulmonary fibrosis. We found that the broad category exposure to gas, vapor, dust, and fumes could contribute in some way to this disease. And the attributable fraction was quite high, 26%. I must say that the epidemiology of idiopathic pulmonary fibrosis is quite poor, actually. We have very few studies, even the general epidemiology and also in the occupational epidemiology of IPF. So this is also an invite to contribute a bit if you have a databases or if you have something to this, to the epidemiology of IPF, which is really quite neglected. So we have this interesting data, but we have to weight them on the end of, let's say, the small evidence we have right now. And it's the same when we look to the several risk factors of IPF, especially metal dust, wood dust, organic dust from agriculture. They are contributing a part to that kind of disease, but just imagine that the articles quite few. And also silica. This is interesting because all the study we consider, they excluded silicosis patient, asbestosis patient, or other kind of diseases that can be secondary. So even if we are not talking about silicosis, but the typical IPF pattern, silica could have a role. And don't forget that this is coming from Barcelona, interesting study from Professor Morel and the group in Hospital Valdebron. They found that half of the patient previously classified as IPF can be hypersensitive pneumonitis, chronic hypersensitive pneumonitis. And this is another kind of problem we have in studying these diseases, because the classifications and the definitions of the disease are changing by time. So what it was in 2011 is not what we have in 2020. So that's a bit difficult to study that. Talking about hypersensitive pneumonitis, what we found was that the contribution, the occupational contribution, is 20%, around 19%, let's say. And it's quite astonishing because we consider always chronic hypersensitive pneumonitis or hypersensitive pneumonitis in a broad sense like an occupational disease. Do you remember farmer's lung? Well, the trend in the last years is to consider a more environmental disease. The occupational contribution of to the etiology of HP is not at the population level is not that important. It seems that the environmental causes, the indoor exposure, the live exposure, can be more important, even if still neglected. This is the case of sarcoidosis. Sarcoidosis is a granulomatous disease unknown by the etiology. And you can see here, if you consider the beryllium exposure in a population-based studies, well, 30% of subjects in some way classified as sarcoidosis patients are instead berylliosis. So think always, because beryllium is everywhere, think always when you have to come up to a sarcoidosis patient that maybe he can be exposed and even still exposed, that can be very important in the, I mean, in the treatment of the disease, to something that caused that disease. So even if these data are limited to beryllium exposure, mind always that a part of the sarcoidosis that we can see is not sarcoidosis, but berylliosis. That is, as many other work-related lung disease, completely not differentiable from the non-occupational sarcoidosis. I would conclude this first part of my talk talking about another common disease, pneumonia. Pneumonia, especially lobar pneumonia and streptococcal pneumonia, seem to be work-related lung disease in some extent. This is something coming from the past. Since 1980, we have some report of higher risk in welders of pneumonia. And this is the reason why nowadays in UK, welders are having anti-pneumococcal vaccination for free. And what we found that in a so-called vapor, gas, dust, and fumes exposure, we can see that 10% of the pneumonia are in some way relate to this kind of broad exposure. This risk, or at least this fraction, is even higher when we consider just welders, cohort of welders, as you can see here in this lower part of the table. And this attributable fraction increased to 40, 60, 50, making really kind of connection between this specific exposure and the disease. This is a kind of overall picture of our statement. And as you can see, to summarize, asthma and COPD confirmed the population attributable fraction of around 14–15%, which is not the smoking for COPD or other kind of exposure for asthma, but it's something important, 15%. This fraction increased up to 26 or 30 in the case of sarcoidosis and IPF, but just keep in mind that these kind of estimates are based on a kind of poor epidemiology. Not poor in terms of quality, of course, but poor in terms of number. And please remember also that HP is something that is everywhere. Sometimes we think about HP as an occupational lung disease. HP is a part contributed by work, but also a lot from the environment. And then finally, also infectious disease can be in some way related to the occupation, to the workplace, to this kind of dusty workplace I mentioned before. And this first part of the talk about the importance of occupation in the etiology of common disease is also supported by the observation that the common occupational lung disease are declining. This is the example of UK, where occupational asthma is declining, both in the diagnosis and recognition, of course. But then, should we still pay to occupational lung disease? Or it's just something that is not important for clinicians or for other physicians, but just for occupational physician? My answer to this question is yes. Yes, of course, because occupational lung disease are still among us. This is something that can help to support this answer. As you can see, for a very occupational, let's say, disease like coal mine dust lung disease, where the burden is 100% occupational, you can see a very interesting and important decline over the last 50 years, sorry. But just look, even if we almost touch down in 1999 period, then you can see a small increase. And why there was this small increase in this disease? Because we are not aware. We are forgetting this kind of disease. We are paying less attention, and that can be a problem. Be a problem because there is less interest, and sometimes all treat are in some way hiding under new settings. It was the case of the epidemic of silicosis among Denims and Blaster in Turkey. It was really an epidemic, and the astonishing fact was that workers were very young, and many of them died this disease. More recently, another new setting come up as a high risk work for silicosis, and is the artificial stone. Artificial stone are the kind of board we have in our kitchen, in our bathrooms, are very nice, very durable, very easy to mount, quite economical if you compare to the marble or to other kind of traditional material. But unfortunately, they are made on quartz. They are silica, 95, 97%. So all the workers dealing with this kind of board, especially those who are adjusting the board to keep in your kitchen, are at high risk of this disease. And as Denims and blasting is a deadly disease, many of these people, young, 30 years of age, 40 years of age, 50 years of age, are dying for this kind of exposure. To keep in mind a bit better this concept, I would introduce a case that we have some year ago in Perugia. I'm talking about a male of young male, 41 years old, non-smoker, and athletic one, ex-volley player. He reported to his GP an exertional dyspnea in the last 2 years, increasing a bit, not very tough, but it was increasing day by day. The patient report no weight increase. The clinical examination was completely normal. The spirometry was normal. The DLCO, the diffusing lung capacity, was normal. And of course, the cardiology evaluation was normal, including echocardiography. Lab exams were completely normal. And what was wrong with him? So according to his GP, he performed a CT scan. And as you can see in this CT scan, in the lung, he had these nodules, a lot of nodules everywhere. They seems not to be linked to lymphatics. So first of all, the GP and the clinicians and that support him in the diagnosis thought to tuberculosis, or in a differential diagnosis to sarcoidosis. And then he performed in Perugia CT scan, microbiology, bronchoalveolar lavage, and even a lung biopsy. And we excluded tuberculosis, sarcoidosis, and also another granulomatous disease we talked about before, and also hypersensitive pneumonitis. So at that point, we looked through the job. And what we told us that he is a very young owner of a small goldsmith workshop. Since the age of 20, inherited from his father, who died for cardiovascular disease. He was never, and then of course, when we talk about goldsmiths, I say, okay, maybe he's polishing and finishing the surface of the jewels with some kind of sand, so he nails sand. And he said, no, I was never involved in finishing and polishing. I'm doing gold and silver casting. What is gold and silver casting? Gold and silver casting is something specific. As you can see here, normally the goldsmith produce a model in wax. So this process is usually named lost wax casting. This model in wax can be modeled very easy because wax is very easy to model. Then when you have this model, you put in a kind of bucket like this one, you put in the tree with this model. And then after that, you cover this bucket with some kind of material that they call gypsum, like calcium carbonate. And then the gypsum solidified, and after all, you can heat the gypsum, and of course the wax inside, and the wax melt away. So you have a negative of the ring, the nice ring we have before, where you can pour gold or silver or platinum, whatever, to have finally this negative filled up by the precious material. And then you break the gypsum and expose this ring outside. Then you finish in the rings, cut the rings and so on, but this is the process, the process of lost wax casting. And then we think, but what is this gypsum? Strange. The bag where the gypsum was in was a white bag with any kind of label, so it was quite strange actually. When we ask to the companies about what is gypsum really, it came up that it was silica, 90%. And unfortunately, during the process of making this bucket fill up by silica, the working environment was really very dirty. You can find some residuals here of this silica everywhere. So, and it was when we go in to the place to see what is going on in this place. So the people, the person, the subject, this patient have silicosis. And then we found out that 23 workers on 100 working in this kind of environment with silicosis. So a small epidemic also in this kind of trades. And what impressed us quite much was the age. They were very young. The mean age was 40. And some of them have a very bad disease, a very bad silicosis, like an accelerated silicosis, and we don't know why. So we studied the samples in a vitro study, and we found that the fibrogenic activity of this kind of silica found as a gypsum, let's say, was really much higher than the usual silica you can find in a tunnel or in quarry or everywhere. So this case, and what I said before, in some way is to stress the importance to take an occupational history beside the normal anamnesis that you usually take in your clinical duty. But it's very important before taking an occupational history to do a very detailed anamnesis, general one, doing also clinical examination. Your ear, your hands are still important, especially in lung medicine, actually. And also prescribe the right exams, can exclude or include the diagnosis. Why? Because it's quite simple. Without a disease, there is no work-related disease. So it's important the workplace, but never go ahead. Always stand on the shoulder of giant. Stand always on what you mean is consolidate with your clinical practice. And when you take an occupational history, what to do? First of all, be patient. It could take longer than you expect, but it's also a way to make a connection with the patient because you are going into something that he knows very well. So he can trust or she can trust more if you're having this kind of talk about the occupations she or he had during her or his life. And another thing is very important. Job title is not enough. Just remember, we say, okay, he's a goldsmith, so finishing, polishing. No, 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 come on. First of all, you have to tell what you are doing really. Yes, you are a goldsmith, but what are your tasks? Because from these tasks, you have also finally something that from the, I mean, another view. In this case, maybe sometimes could be interesting also to visit the workplace. And of course, you have also to consider exposure duration and intensity. Do not stop on the current job, because maybe the exposure given this disease is passing time. Think about that. It is a lot of diseases, occupational diseases. We're talking about silicosis, asbestosis, which need a latency period. So if you limit the interview to the latest job, you can miss a lot of important details. And of course, you have to respect the normal criteria for causality when you have to link the occupation to a disease. The time is important in this case. If you have a reversible disease like asthma, just keep in mind occupational asthma, there is the link of reversibility. Reversibility is very important because give you an idea about how the exposure works. And of course, also exposure response. If you increase the exposure, you can have a more response. Not always. Think about allergic diseases, work-related or occupational allergic diseases. Usually they need just a little bit of a compound of something to give you. So the exposure response sometimes is not present. The strength of association and also specificity are other two important points that you have to keep in mind when you're taking an occupational history and you want in some way to explore an eventual link between exposure and the disease. And also consistency, and if you have no previous data, because maybe the compound is, or the risk factor is new, you can go by analogy and of course biological plausibility. So my aim during this talk is to stress the idea that beside the usual suspects like smoking, like food or diet in a broad sense, clinical exercise, in multifactorial lung disease, there is also the occupation, even in 2020. And also the other thing that I want to stress is that occupational lung disease are not dead. They're hiding under new settings, under new risk factors, but they are still there. So my take-home messages are clinicians are really crucial for work-related lung disease immersion. Any kind of new observation of lung disease come from a clinician, from a single case, not from the epidemiological study. The epidemiology came later at least. The first attempt is a single physician, the GP, that maybe can be occupational, can be work related. So clinicians are very important. Mine always occupational exposure in, as I said, common diseases like COPD, asthma, especially when they are multifactorial. And keep in mind that all risk factors can be in new settings. The last message I would send is that diagnosis and occupational disease and also an occupational lung disease in one patient could save thousands of lives. All the workers that we saved in the goldsmith sector, they will be never, quotient of this problem, but we saved them. So that's the reason why it's so important to study not just the disease, not just the usual suspect, but also work-related risk factors. Thank you very much for your attention. I will switch on the video, and of course, I would leave the stage to Dr. Narmin Kassam and of course Giovanni. Please.
Thank you, Nicola. Now, if Narmin is connected right now because she was still in a meeting a few minutes ago. Anyway, we have a few questions from our audience. And Dr. Duran-Moreau wondered if the analysis you did in the ATS-ERS statement took into consideration also the geographical origin of the studies or of the patients, since epidemiology can be very different depending on the, the preventive measures in different countries.
First of all, I would thank Dr. Kentin Durant. I'm sorry for, yes, about this question, because it's one of the limitations of this kind of statement, actually. What is clear that the reason why the attributable fraction that we found is still so high is also because new countries are entering this kind of studies. So if you check the list of countries involved in the 2003 statement and you compare to the 2019 statement, you can find in 2019 statement a lot of articles coming from China, from South America, from other countries than the Western countries. So it will contribute to keep high, because many of the dusty trades moved to these countries, actually, if you compare to, let's say, 60s or 70s and 80s.
Thank you, Nicola. We have actually a couple of questions from Dr. Straube. Actually, I forgot to tell that Dr. Murgia was invited to Edmonton to give a lecture in June, but unfortunately, because of the pandemic, we had to postpone and then to have his presence like this virtually. And the invitation was from both sides, from me and Dr. Straube. So Sebastian is wondering actually about the multifactorial disease. How does the Italian compensation system work? Are they fully recognized, or there are problems about?
Thank you, Giovanni. I see the question in a question box, so thank you very much. And thank you, Dr. Straube. The Italian compensation system do not recognize work-related lung disease or work-related disease in a broad sense. It recognizes just occupational disease, like occupational lung diseases. So this kind of multifactorial lung disease, like work-aggravated asthma or COPD, are not fully covered. We have a list of occupational COPD. So if the workers is working in one of these sector, can be compensated, but it's not for work aggravated asthma, where the worker is not compensated. Then the system has a very strange, a very strange behavior. So if you want, as a worker, you can bring documents, healthcare documents to support your claim of compensation. But unfortunately, usually our insurance for workers will not recognize so often this kind of self-reported work-related disease. I see another question also from Dr. Strada. How many specialists in occupational medicine do you have in Italy? In Canada, just 138 million people, 63 of the population of Italy, there are about 70. In Italy, we are 3,000, so quite many. But active, we have 1,800 specialized after 4 years course after medicine degree of occupational physician. There is no difference between occupational physician and physician specialized in occupational medicine. Is the same framework.
We have also another question, Nicola, in the chat box from Dr. Duran Moreau, and is wondering if there is any progress in the diagnosis of chronic beryllium disease, if there is anything more than just the lymphocyte stimulation test.
And Giovanni knows about that because I asked him several times. Actually, in Italy, we are performing beryllium stimulating test just in Perugia. Is the last. This is the unique place where you can do this. Unfortunately, this kind of testing is quite uncommon, not just in Italy, but also outside in Europe and even in other places. I know that it's quite, it's rather quite common in US, even if usually it's NIOSH doing mainly this kind of testing. So to really investigate chronic beryllium disease actually is quite difficult.
We have another question from an anonymous attendee about silica surveillance program in mining. If there is anything done on a regular basis also in Europe or in Italy, as far as you know.
Okay, I can say that for Italy we have a regular health surveillance problem. That is the reason why we have so many occupational physicians for any kind of risk factors in the occupation. So if you have any kind of enterprise and if you have a risk inside the enterprise, you have an health surveillance problem. This health surveillance program is managed mainly by physicians and occupational physicians, of course. And for silica, it's usually a regular yearly health surveillance, which could be made on the clinical base using diffusion lung capacity, spirometry, and in some cases also radiology. The use of regular CT scan is avoided for, of course, radiation issues, but there is a specific program in the usual chest X-ray to highlight cases. Many of our occupational physicians are B-reader by ILO.
The next question from Dr. Vetanagan is also continuing on this note. So Dr. Vetanagan is wondering if there is a mandatory reporting for occupational disease in Italy or European countries.
In Italy, there is it's mandatory. We have a list of diseases that we have to report in a compulsory way. Otherwise, the physician can be in some way judged and have problems if you are not reporting that. Of course, the system of checking and surveillance of this reporting is quite lacking actually, but still it's a requirement by the law to report this kind of occupational lung disease like silicosis.
Thank you, Nicola. And this is very important because if I understand correctly, so there is a yearly follow-up for the workers considered at risk. And this follow-up is performed often by private physicians, right? Not really directly connected to the state.
Correct. I mean, usually it's made by factory physicians that are specialized in occupational medicine, working as a private or in consortiums, but at least they're private usually physicians. It's not the government that is taking care of this. The government is checking if this activity is made in a correct way or not, but is not taking directly uh, this duty.
Thank you, Nicola. Now, I have a couple of questions for you, right? Because the lung is the widest surface of our body, 76 square meters, more or less. And
Yes.
we breathe every day the air that will be contained basically in a pool, in an Olympionic pool of 200 meters. And therefore, it's easy to understand why occupational exposures are so important for lung disease. Um, Very often on this side of work, we tend to label diseases as idiopathic, right? And I believe this is a mistake, and we should probably have a tighter connection with occupational disease. No, you are a little bit of a crossover because you are also an allergist and work in a different setting. But what do you think about that?
Thank you, Giovanni, for this question. Yes, it's really very important because eh, continuing the exposure can be very dangerous for the patient. We have plenty of examples about that. We have, for instance, a worker working in a special kind of factory producing cables, the cables we use to connect the world, let's say. And these cables are covered by a kind of plastic stuff, which is made by isocyanates. The isocyanates, as many of my colleagues, is causing actually asthma. But this guy presented something like IPF. And this IPF was a kind of IPF very, very quick in made worsening, really very, very quick. So the other clinician said, but why? I mean, why is so fast in giving him respiratory failure, oxygen, and so on? Why? And it was because it kept this exposure, because they say, no, isocyanates can give just asthma. So please go ahead, do the works, no problem. Unfortunately, isocyanates are correlated also to hypersensitive pneumonitis. And when it comes to Perugia, and we do a work in parallel with our clinic of respiratory medicine, especially the colleagues that you may know, like Stefano Baioni and so on. Those guys say, okay, why? It's so fast. So we found EGG against isocyanates. So he developed a chronic hypersensitive pneumonitis and not an IPF. And unfortunately, he died for that. So early recognition of a possible risk factor of a possible occupational disease could save this guy. So that's the reason why we need an interconnection very, very tight between the clinical world and the occupational medicine world.
And that leads me to my last question for you. So the hardest part of this workup is to tell a patient, I'm sorry, you have a disease that is probably worsened by your occupational exposure. It's not caused by your occupational exposure directly, maybe, and you should stop working in that setting. And this is very often impossible for the patient. How do you address these problems?
Again, it's really important to have a very solid clinical background also for occupational physicians. Without a clinical background, occupational physicians is an half, is not a complete physician. Just imagine that we have this problem of occupational asthma, and what the compensation system give to a person who has occupational asthma in Italy is very, very poor. It's really very poor. And if you have the owner of, let's say, a bakery, you have to close down the bakery. And what the government give you is nothing almost. So there is an attempt also, even if it's very important, to avoid the exposure in floor and baker asthma, of course. But there was an attempt by our colleagues in Strasbourg in France to keep these people working, because they can't stop working actually, because if they stop working, they lose their life. So they keep them, giving them omalizumab, the anti-EGE, and they have a very important result. So 90% of these patients treated by omalizumab, they keep the work as the owner of the bakery. So that was something important. So we have always to connect preventive medicine to what is the outcome, so the clinical medicine.
Good. Thank you very much. I don't see more questions, but the session was very interesting.
Thank you.
And we learned a lot of things. Thank you. You gave us also the opportunity to think about something else.